that. Okay, so now we are recording, everyone. Okay, and I'm going to go ahead and share my screen so we can go ahead and discuss. And if I answer a question, just get out there and answer. Say, this is Jessica, I know the answer. Or this is Michelle, I know the answer. Okay, all right. Don't let me be the only one talking. Okay, you got it? All right, this is fun. This is maternity. This is a great class. All right, so let's go ahead and share my screen in my PowerPoint. And let's go back up to here. Here we go. Can you all see my screen?
Mm-hmm.
Okay, good. Love to hear the yeses.
It's
all
better
right.
from last week.
I know. I spend every week is better. It's gonna happen. Let it happen on week 1, right? Okay. So I hope you like my PowerPoints. There's a lot of time that goes into all these, and I'm just gonna start out with chapter 4. Okay, and it's prenatal care and the adaptations to pregnancy, how the body changes to pregnancy. Okay, and I sent out a cute little cartoon just before we started our class. And what we've done in the past is my students have printed that up and they've actually colored it in. I had students that handed me some really pretty pictures. So what it is, it's like a concept mapping of all the different body systems that go under change during pregnancy. And if you see that, this is a remarkable. I think us women, we're really remarkable people, I think. All righty. What do you think?
Absolutely.
I know.
Oh,
I know. How you doing, my professor?
I'm so glad to see you. Go ahead and sign in on the chat, okay?
Okay.
All right, let's go ahead and start. All right. The phases of pregnancy. We kind of touched on this a little bit. Go ahead and mute yourselves, everybody, because I'm hearing some feedback.
Okay.
So the phases of pregnancy would be like antepartum, which is before birth. Then you got the intrapartum, which is during birth. And then you got the postpartum. We kind of touched on this a little bit last week, okay? But the reason why I'm just going over those is because you probably hear me say this. This is antepartum, this is intrapartum, this is postpartum, okay? And we have certain prenatal care providers. Now we have obstetricians, and there's your MDs, and they are also surgeons, by the way. And then you have your family practice physicians, where they can take care of the like a low risk pregnancy, and they work in the hospital settings, but they're not surgeons. And then you have your midwives, my favorite group of people, and they're RNs who have a master's degree, who have gone on for an extra certification. And it takes about, I tell you, it's a rough program. It takes about 2 to 3 years. And then you have your nurse practitioners, okay? And we all work together as a team, to take care of this pregnancy. And certified nurse midwife, they take care of most low risk pregnancies. So it frees up the obstetricians for those high risk pregnancies where you have, women have preeclampsia, previous diabetics, type 1 diabetes. You have women have lupus. They all have babies. Yeah. Okay. So when I ask you what the major goals of prenatal care, what comes to your mind on prenatal care? What's a goal? Well,
Healthy mommy, healthy baby.
Exactly. That's my old saying. Healthy mommy equals healthy baby. So we want to ensure that. We want to ensure a safe birth for mom and child. When I worked labor and delivery, that was my goal all the time: safe birth for my mom and the baby. And when they're getting their prenatal during antepartum care, you're promoting good health habits and reducing the risk factors. That's what's so important about that first visit, okay, to the obstetrician or the midwife. We want to get all those, we want to get a good history, because I want to know if she has problems. I want to prevent any more further problems. I want to teach good health habits. And you know, these health habits like proper nutrition, getting sleep, taking care of oneself, those are good for the rest of her life. And then I want to educate her, or here is self-care for pregnancy. Because a lot of stuff, you know, goes on. You have skin changes in pregnancy that she has to take care of. And she might get, you know, other complications during pregnancy. So we want to make sure that she knows how to what? Take care of oneself. Provide physical care, absolutely. And then prepare the parents for the responsibilities of parenthood. A lot of times, you know, in order to drive a car, you have to get a license, right? I always think about this. And you go through a schooling and you got to take a test and then you're tested. Well, parenthood, there is no test. There is no like preparation, right? I mean, you know, you find out you're pregnant, you go, oh, okay. And there's no test for it. So we have to prepare, and that's part of the care that we give, is we prepare the parents for responsibility. And that's a big responsibility. Okay, so here are your prenatal visits. So ideally, in the perfect world, prenatal care should begin prior to the pregnancy to assist the woman in being in optimal health prior to conception. Yeah, if she's, that would be a perfect world. Come in before you get pregnant, all right? Because by the time that we know that you find out you're pregnant, you're already what, about maybe 6, 7 weeks, maybe. And so all of a sudden you go, you know, you're not eating right. You maybe had a couple drinks the couple of weeks ago, and you didn't know you were pregnant. So really the optimal time is before it all starts. And then the gestation of the woman at the first prenatal visit, it will vary. Some people come in, I tell you what, the AMA patients, the advanced maternal age patient, she may come in as soon as she misses that first period. I'm pregnant, you know. Another woman may come in, may say, I can't be pregnant. And all of a sudden she misses the second period. I think I'm pregnant. So that's where the gestational age will vary from woman to woman as to when they come in. Majority of the ladies like to get in there about 8 to 10 weeks. Okay, so again, preconception care, you identify risk factors, and you can see that is in red, and it may be changed. You want to reduce the negative impact on the outcome of the pregnancy. Remember, I want healthy mommy, I want a healthy baby at the end, okay? Because if you're a type 1 diabetic, okay, those type of patients have to be watched very, very carefully, because their outcome could be basically, may have some fetal abnormalities at the end. So you have to really worry and make sure that we do what we can do to reduce risk factors. Nutrition. Hey guys, yeah. Okay. I would get a plan, you know, tell me what you eat in a day. You know, you'd be surprised when you ask people what they eat in a day. And it's like, what nutritional value is there? Okay. And then immunizations. The big one I have to worry about is rubella. And so if she has no idea, then on that first prenatal visit, one of the blood tests I would test for rubella. I want to get a rubella titer. Because rubella, now listen up, you cannot give the live virus, you cannot give rubella during pregnancy. Cannot. Okay. So I want to know what I'm starting out with. And then I wanted to ensure the adequate intake of folic acid. Now you see that is highlighted. It's important, folic acid. And so why? It's because research has shown that if I take in 400 micrograms of folic acid in the beginning of pregnancy, I can prevent open neural tube defects, such as spina bifida or hydrocephalus. So this is why folic acid is so important. So on that first visit, I'm going to get a good complete history, and she's going to get a physical. Prenatal care is kind of a primary example of preventive medicine. We want to prevent things from happening. Like if she came in and she had a medical history of hypertension. All right, so I know that she's coming in with hypertension. What am I going to be worried about? What do I want to prevent? I want to prevent preeclampsia. So I want to prevent any of that from happening. All right, because preeclampsia goes from preeclampsia to eclamptic, and then she has seizures, and we'll get into that when we get to that one. All right, and then I want to identify any other problems that may affect the woman and her developing fetus. And that's also making sure that she's in a safe environment, okay? Making sure that she's not a product of IPV, intimate partner violence, because that would also affect her and the growing, developing fetus. So these are things we're looking at. The first visit is a lengthy visit, and I usually warn patients when they come in, you're gonna be with me for a while, okay? Because I'm gonna get a medical history, plus I'm gonna get a obstetrical history. All right, so here you have your components of that prenatal visit, the health history, and you always, always, always want to ensure confidentiality during the interview process. Yes, and the obstetrical history is one that I'm looking at to see, well, what number of pregnancies is this? So I'm going to do what we call a GTPAL. That's the gravative term premature abortion and living. And I did put that in your study guide, and I wrote it out for you. Reason why I want to know the difference. Is she coming in? Is she a prima? Is this the first time that she's pregnant? She's going to be different than a lady that is a multi-prima. She's going to be different. She's going to say, I don't have, the multi, she's been through before. Okay. The prima has not. And she's scared probably. She needs a lot more what I called a TLC education, because she probably has a lot of questions. Okay. And then I want to know her last normal menstrual period. Now, some people have irregular periods. I want to know when was your last normal menstrual period. And I want to know how many, and I go into the cycles and everything with her. Okay. All right. And so contraceptive, these are things I want to know what she was using, if she was using anti-contraceptive, because apparently it didn't work if she's pregnant. Okay. And maybe then I make a notation, because then at the end, when she comes back in for her postpartum visit, I'll say, well, we didn't do too good on the pill. Or she'll say, I don't want the pill again because I skipped the pill and I have a baby. Then we'll go into maybe an IUD or some other form of contraception. Again, the medical and surgical history, and the surgical history is important, because if she's a multi, then if she's had a C-section in the past, I have to know that. I have to know that she's had a C-section, because if she wants the VBAC, which is a vaginal birth after cesarean, I need to have the surgical report on her, because I need to know what kind of incision is on the uterus and on the skin. Well, apparently I can see the skin easily, but it's on the uterus that I had to worry about. Okay, so these are things that I'm thinking about as I interview my patient. And then I want to know about her any family history, and then her partner's history, her husband's history. That's all has to do with genetics, because I'm already thinking, certain religious, like in the Jewish faith, they're more prone to like Tay-Sachs disease. So I want to know what's the family history here. Both women and partners history, again, to identify your risk factors, and the psychosocial, always very, very important in maternity.
What happens if one of the parents of the fetus is adopted and there is no history?
Then we don't, but then we have no history. Then I make a notation that husband was adopted. He has no history. He has no known history. And then I ask him, well, can you tell me about your health? Yeah. And then he'll tell me, well, I go to my doctor and, I'm being treated for this and that. And I go, okay, I make a notation. So we just keep those in mind. We do the best we can when it comes to things like that.
If you
Okay.
don't get all the information, Professor, and you don't know like the background with, all the blood and all that stuff, do you just like draw titers to eliminate like?
Oh yeah, if he doesn't know his blood type and stuff, yeah, we can draw blood on and draw a titer on, get a blood type on him, especially blood type, because especially if mom, remember on that first prenatal visit, that RH factor, I want to know. I want to know if she's positive or she's negative. Because remember, mommy is RH negative, then we don't know the blood type of the baby, right? So we're going to give mom RhoGAM during the pregnancy. Yeah. All right. All right. Physical examination objectives. Well, we want to see how healthy she is. Not every woman that comes through that door is in good health. All right. Most women really, we work 2 and 3 jobs sometimes, and we just working ourselves, and so we're not taking care of ourselves correctly. See a lot of that. I want to get a baseline weight, and the reason why is I want to make sure that we're not gaining too much in the beginning, and I can see the gradual changes. Baseline vital signs, blood pressure. Definitely. I want to get a good blood pressure because I want to make sure that we don't escalate. If you have you remember the 30-15 rule, where, your blood, if your systolic changes more than 30, you're in a red zone. If your diastolic changes more than 15, you're in the red zone. That's the 30-15. So you have to be careful, because then what am I thinking already? I'm already thinking, oh, she's set up could be for preeclampsia. Again, nutrition, as you can see in all the slides, they have you can see the general component of every one of them is nutrition. All right. What mom takes in goes to baby. And mom has to take in enough calcium and all that for her too. Because I'll tell you what, this little growing fetus inside is going to take from mom. All right. He's smart. Okay. He's going to take from mom, and mom gets depleted. And I've seen a lot of women lose a lot of teeth during pregnancy, is because they didn't have good dental health beforehand, and then they weren't taking in enough calcium and their vitamins, and their teeth became loose. Okay, so we want to worry about that. And then I want to identify any current physical or social problems. And then again, I already talked about maybe abuse. It's called IPV. And then I got to determine that first visit, her due date. Okay, so I can do the due date in a couple of ways. I can do as a nurse easily by doing the Nagel's rule to get her estimated date of due date, estimated day of confinement, EDC or EDB. She wants to know, what am I due? So if you do a Nagel's rule, you're going to count back 3 months, and then you add 7 days to the first day of your last normal menstrual period. Now, obviously, if it's in like June, you're going to proceed to the next year, okay? Because our pregnancy, remember, is what? 9 months. Okay. All right. And that's an easy way. Now, another way we can tell her date of her due date is we can do an ultrasound in the first visit. And usually about 10 weeks, we can do what we call a crown rump measurement, crown rump. And we put our indicators, our ultrasound indicators, one little arrow on the crown, which is the top of the head. That's called the crown. And then on the rump, we put on the other indicator, and we measure it out. And then we have a chart, and it tells us for how many centimeters the fetus is measuring when she's due. So that's a really good way of knowing when you're due. Okay. Now, here's your brain teaser. Everybody awake? Okay. So if I asked you, a woman is coming in for her first prenatal visit. it is determined that she's 8 weeks pregnant. Which tests are typically performed at the first prenatal visit in a low-risk pregnancy? Select. Okay, so what we got, which one?
B as in boy.
Okay, got B. Okay, what's
B
the
as
next
in
one?
David.
A,
Complete
B, D, and
with blood count.
Okay, B. Okay, so I'm hearing B and D
And E.
and E and A. Right,
So it's all of them except for C.
all, yes, exactly. All
this
right,
glucose comes like what, how many, like at what, 26 or 27 weeks, Professor?
yeah, that GTT, yes, 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 it comes later, like 26 weeks. All right, so this is, remember, now look at the words in that question. Okay, first of all, first prenatal visit.
8 weeks.
Number 2, she's only 8 weeks pregnant. A lot of questions in a maternity, you have to look at the weeks, okay? Because the care is going to differ from the beginning of pregnancy, the middle of pregnancy, or the end. That's another clue. And then which tests are typically performed at the first prenatal visit in a low risk pregnancy? That's it, the low risk. That tells me, okay, she's low risk. And so therefore, I got to know HIV. I want to do a CBC because remember, I want to get the baseline hemoglobin hematocrit. I want to get the rubella. Remember, we just talked about rubella. Cannot give rubella during pregnancy. Cannot. If you write that down, we do not give rubella during pregnancy. And then your vaginal cultures.
They don't do the RH factor though? I thought they did the RH
Yes,
factor.
they do, but this is my brain teaser. Got it? Yeah.
Professor, if the titer comes back that they haven't been vaccinated, do you just wait until the end of the pregnancy?
Yes, we wait till she delivers. And when she's on your unit in postpartum, you can give her rubella at that time before she leaves the hospital. And she can breastfeed. Okay. Yes, Jessica, to answer your question, there's a whole, in your book, there's a whole list. But this is something I'm just focusing on right now. It's a little brain teaser for you to know. All right, let's go on. Yeah, usually if you've had a baby, usually you see like 4 tubes of blood being taken out of you. Usually, and a lot of times we used to draw blood right there, and I had people fainting in the lab because of all the tubes of blood being taken out. It's a lot of tests, and it's in your book. Okay, now let's go over the pelvic examination. Okay, so remember we talked last week about the evaluating the size, the adequacy, and condition of the pelvis. Now, if I ask you, I'll wait to that. There's another brain teaser on that one. Types of pelvises. Okay, so these are your signs of pregnancy. So I have probable, I have positive, and presumptive. Now, let me go back up. Just keep that in mind, and I'm going to go over each one in just a second. Now, this is called the recommended schedule of prenatal visits. What kind of pregnancy does it say? Uncomplicated. Okay, so from conception to 28 weeks, she comes in every 4 weeks. That's not too bad. And you'd be surprised. It's like pulling teeth sometimes for them to come in at least once every 4 weeks. Now, if the doctor, if he discovers something or is in your history, then we might move that up to like every 3 weeks. Okay, that's up to the discretion of the healthcare provider. Then from 29 to 36 weeks, you have every 2 to 3 weeks. Again, according to your history. And what's going on with the pregnancy? You know, maybe you acquired something, you know, during the pregnancy. Maybe you came down with being a gestational diabetic. All right. Then from 37 weeks to birth, you're coming in weekly. And sometimes if you have complications such as you got gestational diabetes, we'll have you come in more to do what we call NSTs, non-stress tests. okay, non-stress tests, and we'll go over that. All right. Now, I have a safety alert in here. All right. Early and regular prenatal care is what? It is so important to reduce the number. Go ahead and put yourselves on mute, okay? For reducing the number. I'm hearing little ones. That's okay, but go ahead and put it on mute. Okay, thanks. So it's important for reducing the number of low birth weights. We try to reduce that number. We don't want these babies born what? Premature and low birth weight. All right. So again, we're trying to reduce that morbidity and mortality for both moms and newborns. Okay. So if you think about it, how can nurses strive to reduce the number of low birth weight infants?
Educating the new mommies before and after, especially if they're like a regular patient coming to the OB, like, and you know, that's what I think.
Oh, sure. It's educating. It's everything we're going over. Education, nutrition, right? Care, her own health. These are things that we can do as nurses. And I tell you, nurses, we're very good teachers. Okay. And we make sure that our patients are getting. Don't use these big, when you're educating a patient, by the way, don't use these big old terms that you're learning in school. You want to, first of all, I always analyze what level is my patient at. Okay. And usually they're pretty nervous. So I'm going to make sure that whatever I say, she can understand. What good is my education if she's not understanding it? Not good at all. So that's what you always look at. You always want to analyze your patient and see. And if they're nervous, just take your time. Because a lot of the information goes what? Right over the head. All right. Okay, so here's your antepartum nursing care. So again, you obtain the maternal history, obstetrical history, and we already went over this, is by the Gravid and Para and the GTPAL. Assist with a physical exam, calculate gestational age using Nagel rule, ultrasound at 10 weeks gestation, crown rump measurement, obtain vital signs. We're going to get a baseline, and this is where I put that in there for you. The average BP is like 90 to 140 systolic. It's on the high side at 140, and then 60 to 90 on the diastolic. But always remember the 30-15 rule. Okay, I went over that with you. And then the average pulse, there's 60 to 90 beats per minute. And average respiration is 16 to 24. Just giving you information to have and to behold. Okay. All right. Here's all the blood work. I think, Jessica, you probably like this slide because here's all that tests, all that blood work. Here's your HIV, your CBC, rubella, hepatitis B. RPR is your syphilis test. A VDRL is your venereal disease research lab. Again, they're going to look into that. If a patient comes up positive for any of those, you have to report it to the health department. Your RH and your blood type with your antibody screen. Pap smear. Some women haven't had pap smears. Vaginal cultures. I'm looking for gonorrhea and chlamydia. These vaginal cultures, if she's positive, and she could lose the baby because of these vaginal disease. Okay, and then you have, if you have a patient who has sickle cell, I want to get a hemoglobin electrophoresis level on them. I want to know where I'm starting at. And then you have a urinalysis. And urinalysis, I'm looking for, any kind of protein or nitrites, WBCs, and glucose. And these are things you look in every urinalysis. And if it's positive, if a positive urine means you have WBCs and nitrates, and what are they going to do? I want to reflex it to a culture. Okay, and so I want to know, again, what I'm starting out with. Because a UTI, now listen up, a UTI, we don't want them in pregnancy. Because remember last week I told you the bladder lays right underneath the uterus. When the bladder gets inflamed, the uterus gets affected, and she could have a miscarriage because of UTI. So we don't want that. And later on down the road, she could have preterm labor be related to a UTI. Okay, all right. So that's why every visit, when you go into your OB, you're gonna have what? A weight. We're gonna give her urine, and that's where I'm gonna look for the WBCs, the nitrites, the glucose, the protein. And I wanna make sure everything's okay. I'm going to get a vital signs, going to get a blood pressure every visit. I want to see, are we starting to escalate as we grow now? Okay, so that's another indication that something is going to be going wrong. What do I want to do? I want to prevent my risk factors, right? Prevention. Okay, all right. And again, my HESI hint, this comes right out of your book, okay? Right out of your HESI book. The hemoglobin and hematocrit data can be used to evaluate nutritional status. So if the patient's anemic, then you can give supplemental iron, and a diet higher in iron is needed. Right from the beginning. Now, I put in here because I know that sometimes on exams and HESIs, they like to always put a couple questions on nutrition. So here, this is foods right out of your book that are recommended. So you got fish. I mean, remember, certain fish is okay, and other fishes are not. Anything that crawls along the bottom of the ocean is out. So fish and red meats, cereals, yellow vegetables. Again, make that plate. Remember that plate called My Plate? Okay, and it has, you know, your protein, and has your vegetables, and you want to make it colorful. So colorful vegetables, green leafy vegetables, citrus fruit, eggs, and dry fruits. That makes that beautiful plate very nice looking. Okay, a lot of people don't know about any of that, and I usually told them to go to the website called myplate.gov. And it's a great website, by the way. And it has a really colorful plate on it, and you can really see it. And your book too goes over that. All right, so again, these are just routine assessments. And I know I'm kind of saying it over again, but maybe, you know, this will get really right on the tip of your tongue. Risk factors, always review them and assess for new vital signs. Always evaluate the weight gain, changes, and changes in blood pressure. Urinalysis, protein, glucose, ketones, albumin, blood work. I'm going to what? I'm going to always monitor for anemia. Now, I remember working in the clinic, and I used to do finger sticks, and see where her level was. Okay, it changes. You might give somebody iron tablets. Okay, and you think, oh, I gave her iron, so you chart it down, iron supplement given, but is she going to take them? A lot of times the ladies don't like to take those ferrous sulfates, right? They're big tablets.
Because they make you not be able to poop.
That's right. It makes you constipated. So during pregnancy, don't you have a problem with constipation to begin with? Yes. Yeah. You think I'm going to take a pill now that's going to make me more constipated? No. The compliance, I'm going to tell you, compliance is your biggest barrier. I mean, they don't, you got to be careful when you give somebody like a supplement and tell them to take it. They come in the next time, they'll say, oh gosh, you know, nurse, I'm really tired. You know, I know it's pregnancy, but I'm really tired. Well, let's see. Are you taking your iron? Well, once in a while. Well, if you took it as prescribed, you probably would feel better. You have more energy. Okay, I'll try. I'll say, just try. And then I go over the diet and I'll say, are you eating your green leafy vegetables? Well, no, they don't really, you know, do much, you know, my taste. I don't really like them. Okay, so now you see what I'm coming at is compliance. All right, every time she comes in, I'm going to do a fundal height. Now, how you measure is you put your little tape measure down by the symphysis pubis, and you come straight up on the linea nigra and up to the top of the uterus, which is called the fundus. And you can feel that, and you want to measure, and it'll measure in centimeters. Now, if I have a patient that is 28 weeks gestation, okay, then she should measure 28 centimeters. Fundal height. Now, write this down. The measurement of fundal height should be equal to gestational age. All right. Now, this is a good, it's a simple test. It's a simple thing. And every provider, when you got your patient, she's gonna do the fundal height. Is a good indication that if that fundal height is too high, that for that gestational age. So she's supposed to be 28 weeks gestation, and she's measuring 32 centimeters. We got a big baby. All right. So that I don't have to do much. I know that baby's getting kind of big, or she could have a lot of fluid. So we would probably follow up with what? An ultrasound. All right. If she came in, she's supposed to be 28 weeks gestation, and she's measuring 26 weeks. Do we not have a problem? Yeah, we do. Baby is what? Small, SGA, small for gestational age. All right. So you see, by a simple little measuring, you can tell a lot. And then we know that we have to, something's not right here, and that we have to what? We got to do another test. All right. Makes sense. Then you have what we call the Leopold's maneuver. And in your book, it shows you how to position your hand. And maybe in your lab class, when you have lab, have your teacher go over the Leopold's maneuver, and you go over by the simulator at Noel, and just put your hands on, and you can tell the position of the baby. Okay. And we used to do that just so that we know, okay, we've got the head down and the buttocks up. So I got a vertex presentation, okay? And then you just follow your hand, and you follow all the way around, and you can feel digits come up to the butt and come around the other way, and you can feel what? The feet, okay? All right, I think you'll be probably doing that in lab. Do it, so get your hands on Noel so you can do it. At every visit, you're going to listen to fetal heart tones. The normal fetal heart tone is from 110 to 160. Write that down. So anything below 110 is called bradycardia, and anything above 160 is called tachycardia. So 110 to 160 is my normal fetal heart rate. And it goes like this. Boom, 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 boom. Really, it's very fast. And so today when your patient comes in, you use a Doppler. And the Dopplers today are so great that all you have to do, it gives you a digital readout of the heart rate. It takes like 2 seconds, you know? Boom, 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 boom. Okay, you're good. Years ago, we had to count. Now you try counting for a full minute on a fetus that's moving all around. I'm sure those little ones from the very beginning of pregnancy. That was a challenge. But over the years, the little Dopplers, the Dopplers have gotten much better, much easier for you. And again, nutrition intake, especially in the third trimester. Because the third trimester is a time of rapid growth for the fetus. All right, rapid growth. So write that down. In the first trimester, they usually have some nausea, vomiting related to hormonal changes. Am I really going to be eating green leafy vegetables? I don't think so. Maybe some crackers, okay? A lot of ladies like to eat non-food substance, such as soil and starch, and that's called pica, P-I-C-A, and that can happen. But that's usually in the beginning, and then they have cravings during the pregnancy. But the third trimester is a time of very fast, rapid growth. All right. And then ask her, do you have any discomforts? Or do you have any problems since we last saw you? Because don't forget, you're going to see her before weeks for a while, and then she's going to come in as the pregnancy grows. She's going to come in a little more often. All right. So I have this slide is antepartum nursing care, and I want you to just see the calories. A lot of times on an exam, there could be a question about calories. So you want to increase your intake by how many calories when you're pregnant?
200 calories.
Right. So remember that. And then you want to make sure she gets enough protein. So you're going to increase the protein by 30 grams per day. Okay. And remember, we talked about this already. Get a little meal plan, ask her first, like, tell me what you eat in a day. Okay. And then you make suggestions. Okay. I always want them to buy in to what I'm saying, is because I want them to do it when they leave. All right. So I try to we're a team, and let's work together to get your nutrition where it should be. All right. And then you got your intake of iron and folic acid. And then you have your supplements, your vitamins. Okay. And then we want to increase vitamin A, vitamin C, calcium through the diet. Again, baby will take from mommy, and then mommy gets depleted. And then you want to have some fluids. The body, every cell in your body needs fluids. Okay. So she should get like 8 to 10 glasses of fluids per day. All right. Again, all cells require what? Fluid. All right. Then let's go into how we doing? Okay. 15 minutes. We'll take a break. Okay. So hang in there. Vaginal discharge during pregnancy. Very common. That bacterial vaginosis. Very common. And it's because the body pH is changing too. So there's a decrease in lactobacilli. Sometimes you have increase in bacteria and other anaerobic microorganisms. Don't forget, things happen. The vagina isn't a sterile environment. So you have to keep that in mind. And she may have a milky white discharge. And so you want to make sure that when they come in that you're looking at it. That's in the beginning too. You get those vaginal cultures. I want to know if she's got gonorrhea or chlamydia. All right. And like I told you before, they're often very much associated with what? Preterm labor. Now, when you work in an OBGYN office, you want to make sure that you do everything that you possibly can for her to avoid preterm labor. All right. We don't want any preemies. And so when I have a patient that came into labor and delivery, and she was maybe 36 weeks gestation, we jumped on them really quick. Okay. Because if you can catch them, if you can catch them when the cervix is closed, or at least once, or even 1 centimeter, you have a great chance of what? Stopping labor. All right. But once they get like 2 centimeters and beyond, it's very hard to stop it. And I don't want babies at 26 weeks. I want babies at what? Term. Okay. All right. Now, what's your role? You're going to be nurses, and you're going to do the prenatal care. So I'm going to collect my data. I'm going to identify and reevaluate all my risk factors. Takes time. I want to educate her in self-care. I want to provide nutrition counseling. This is all in a nutshell. And promoting family adaptation to pregnancy. You want to know too, not only a woman has to adapt to all this, but her partner has to adapt. Fatherhood is a whole different ballgame, isn't it? Huh? And for that man, and they have to what? Work together as a team in order to have a healthy baby also. Because we want to keep mom healthy and happy. Okay, so here's some terms related to pregnancy. So I wrote them out for you. Gravida is what?
Pregnancy.
Right.
Mhm.
Null gravida, null, N-U-L-L. Well, that means like she's never had a baby. Okay, you're starting from scratch. Prima, she's what? Her first pregnancy. All right.
Mhm.
Multigravida. They've been pregnant for at least what? at least once and going on for the second time or third. Now, let me tell you, you have a grand multiparous and you got a fast delivery, okay? Those are my patients that have had, you know, six children already, and she's on her seventh, and she comes into labor and she's like 3 centimeters. Don't ever trust that multigravida. No, she's my grand multiparous. And so we kind of have on high alert. So if I have 2 patients in labor, if I'm assigned 2 patients in labor and I got one that's a grand multiparous, I go, hey, when she goes to complete, which is going to be pretty soon, you're going to have to take over my other patient. Oh yeah, don't worry about it. Yeah, go ahead and start. And sure enough, what happens is that you turn your back. Oh, and you hear this, I gotta push. And I go, okay, it's time for delivery. All right. So I love my grand multiparous patients because they do kind of make the process a little bit easier, and they deliver those babies beautiful. Okay. And then para just means the number of pregnancies that reach it to 20 weeks or greater. Remember, what's the age of viability? 20 weeks. We talked about that last week. So these are number of pregnancies that made viability 20 weeks or greater. All right. And my little prima-para, she's giving birth for the first time. So that when you've got somebody in labor and it's their first time, okay, you know, they're going to push a little longer, because don't forget, all that perineum hasn't been stretched, okay? And so these time takes, you know, of essence, you know, time is involved. So your prima-para is going to take a little longer than your multigravida. And because the multigravida has been stretched, just as her labor is going to be shorter than a prime. Now, unless, you know, you're one of those lucky ladies that go pretty fast, but normally it's because the cervix hasn't been open. All right. When you're having your first baby, you know, that's all really tight in there, you know, and it should be. Okay. It's never been stretched, never been open. But once you deliver your first baby, that first baby is kind of special. He's making the way for all the rest of them to come down. All right. So he's stretching everything. And so I always say that for the oldest one, I guess it should be a little more special. He worked hard to get out. All right. And make it easy for the rest of them to get through. Okay. And then I got your other terms. And just want you to, you know, you can see that abortions, the termination of a pregnancy, gestational age is how far along the pregnancy is. We talked about that already. And fertilization age is the time from the fertilization. All right. And then age of viability, and we talked about that. Let's make sure the age of viability is the ability is when the fetus reaches 20 weeks gestation. And that fetus has a chance of surviving outside of mom's womb. That's what it comes down to. It is able to survive extrauterine life. Okay, so that's called viability. And I gave an example to you where when I was in labor and delivery, and I get a phone call from the ER, and they say, Irene, I need you. I got to set a patient up. Okay. How many, first thing I'm going to ask them, well, how many weeks is she? Well, she's 18. No, she don't come up to us. She stays with you. It's because I can't do anything with an 18-weeker. All right. So it's better that she remains in the ER rather than coming up to labor and delivery. Now she's 21 weeks. She's coming to labor and delivery. All right. See the difference? Because that 21-weeker has the ability to survive outside of mom's womb. All right. So here's your term that determine the estimated date of delivery. So remember, your average pregnancy is 40 weeks. And you might put another way, 280 lunar days. And is after the first day of the last normal menstrual period, plus or minus 2 weeks. All right, and we talked about Nagel's rule already. So there it is again, all right? Everybody's good with Nagel's rule. What you do is you take that, what day? The first day. Now I've seen on exam where they kind of confuse you sometimes, okay? But you remember is the first day of the last menstrual period of the or the last normal menstrual period, okay? You count back 3 months and you add 7 days to that first day of your period, of the last menstrual period. Now, of course, if it changes over the year, if it's applicable, you. All right. Make sense? Everybody good on Nagel's rule? All right. And I put another slide in here again to show you, because I know you'll see it again. All right. I think you all got it though, right? All right. So here's your brain teaser. Now, determining your EDD using Nagel's rule for a woman whose last menstrual period began on January the 7th, and I love when they do this, and end on January the 12th. Well, that's a distractor. That little end there and ended on January 12th, that's a distractor. You hear me? So it began on January 7th. So when am I due?
October 14th.
October the 14th.
Yes. Okay. And that's what these questions will do. They'll put in
November,
distractors,
October.
So you count
So
back
you're
January. So if you got to write it on a piece of paper, like
Mhm.
what, December, November, October, it's okay, but make sure you count back 3 months.
Yeah,
add
come
7
back there
Yeah.
and
Okay.
add 7 days.
Yeah, that ended. Now I'm telling you, they do those distractors for questions. I mean, I don't think it's not fair, but you know better. It goes from the first day. Now, some questions have it on where they began. Let's see. You figure from the last day of the menstrual period. No, it's the first day. So how many times did I say that now? First day of the last menstrual period. Count back 3 months, and then you add 7 days to that day, and you got it. All right, that was an easy one because that didn't even give you a year. How about another one? Okay, so a woman's last menstrual period began on May 4th, 2022. Okay, so you're using Nagel's rule. Which date would be correct to estimate her delivery date?
D.
B.
You said D?
B.
David. As in,
So we're going to count back 3 months, right? So that would be what, February, right? And then we add 7 days.
Mars, February, January.
So my first day of my last menstrual period, May 4th,
B, January 11.
February the 11th.
January
And
11.
I'm going to jump the year, right?
Yeah.
Okay, you see that, guys? Does everybody see that?
Mhm.
Okay, I want to hear everybody. Yes. Okay,
Yes.
good.
yeah.
Okay. All right.
For the one
Nobody-
before that,
Nobody
For the-
should get that wrong.
I have a question.
Okay.
From the one before that, was it October 14th?
If you're
October
adding 7
19th.
days, yep,
Okay.
yep. Always remember, count back 3 months, add 7 days. You got it, Mr. Nichols? You got it?
Yeah, it's B, it's 2, October 19.
No. What's 7 7?
It's January 12. You minus, it's gonna be
No,
December.
don't
No.
go by January 12th.
Nick, it's the first day of the period, not the
Right.
end.
It's your first day. See, they're gonna put distractors. See, this is why I put this in here. They're gonna put distractors like that. You don't go
Mhm.
by the end, you go by the first day of that last menstrual period.
Mhm.
Write that down. First day of the last menstrual period. So if my first day is January the 7th, and I'm gonna add 7 days, right? Then I'm gonna.
Yeah, I put January. Okay. I got
Okay,
you.
you
Mhm.
got it?
Professor, are you able
I
to
got it.
see
The first
the
day,
chat?
January, October 14.
Okay, you got it. All right,
Mhm.
okay. Everybody good?
Are you
Yeah,
able to see the chat and questions being asked in the chat at all?
Oh, no, I'm sorry. Are you asking?
There's actually a really good question. I was wondering the same thing for you.
Oh, well, see, I got this. Let me go up here.
Yeah.
Pretty much, I was
If they
just
don't
asking.
remember, oh, if they don't remember when they started, but know when they ended. No,
Yeah.
because
I didn't pay
yeah,
attention.
don't go by that. Your cycle could be, some people bleed for 8 days. Some people bleed for 5 days. Some people bleed for 4 days. That's not a good way. If they can't remember, okay, then what would we do? We would do an ultrasound to do the crown rump measurement.
Yeah, that's
Or
what
the
I had.
HCG, right?
Yeah.
Mhm.
You would, well, first of all, you would do the least invasive, which would be the ultrasound, because it's just external. So you could do it on their 10 weeks visit. You could do an ultrasound. Usually they do that and they get a crown rump measurement, and that would be your good predictor.
So Professor, when would you, so even if that's less invasive, do you think that it will be worth it also just to get like a urine HCG or something? Or
Well,
would it be first thing ultrasound with the
Well,
rump?
you see, with a urine HCG, it doesn't give you the amount of HCG that's being produced. All right. The only way you would know would be to do a serum HCG, and that would be another predictor, because you can do a quantitative and a qualitative measurement on that serum HCG. See?
So it'll be better to do the blood HCG.
Yeah, you could do that, but that's kind of expensive doing that. So we try to keep away from it if we don't have to. But by just doing like an ultrasound at 10 weeks, and everybody, I'm gonna tell you, everybody that comes in wants that ultrasound. Okay. And everybody. And it's nice. They bring their families, and it's a nice time to see that. So hopefully in today's world, where you can have your period, on your calendar when it starts and when it, blah, 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 they usually take out their calendar on their phone and say, oh yeah, I remember, I know when I started. All right, so usually it's not too bad, but there are ways to find out and to measure and to do, and we have our ways, like I just said. Yeah. But for your exam and for your quiz, don't forget Nagel's rule. First day of last normal menstrual period. Come back 3 months, add 7 days, and you got the answer. Okay.
Yes.
And don't forget to advance the year if you need to. Okay. All right.
Mhm.
All right. So everybody knows that, right?
Yes.
All right. I love to see those smiling faces telling me yes. Okay, good. All right, let's move on. We did the brain teaser, which you probably see again. All right, so we're just going to review the trimesters. You probably heard me, go back up. You heard me say trimester, like first trimester, second trimester, and third trimester. Well, we divide pregnancy into 3 13-week trimesters, okay? And what we do, we can gauge, like the first trimester, it could be a period of, I don't feel good, I got nausea, I'm vomiting, I'm tired, my body's going through these changes, I'm not sure I'm happy. It's a time of ambivalence. Also, it's not a lot of fun the first trimester. No. Okay. Now the second trimester is called the honeymoon trimester. And that would go from week 14, and you add 13 to that, up to week 27? Am I right? And that's called the honeymoon. The nausea, vomiting that is associated with those hormonal changes are done with. Okay, well, somewhat. Okay, but most of the time they're gone. Okay, so now it's a time of, wow, getting ready for the baby, and feeling, maybe have some what we call lightning, where baby moves, and it's such a nice time for the woman.
Mhm.
Now, the third trimester is, okay, I'm done. I've had enough. When's the baby coming out, nurse? Okay, I want the baby out now. Yeah, okay. That's it, I'm done. Remember that old saying, you put a fork in me, I'm done? Well, that's what they tell me. Well, let's get you Just get you to the end of pregnancy and I'll be really, really happy. Okay. So that's what happens in those trimesters. And we can, it's nice because you can tell them what to expect, and then we can go over the growth of that. Okay. Now, anytime that you guys put a question in the chat, just tell me so I can look up, because don't forget I'm screen sharing and sometimes it's hard to see that. Did I get everybody's questions so far? Okay. All right. So let's move on. I love questions, by the way. All right. We're going to go over these signs of pregnancy because you will see these again. You got one on your quiz today, and you got, I know, on these. I always like to put
The
this.
restroom is done, Ham, because I don't want to take a break and you're gonna take one soon.
Okay, how about I get through this one? Okay, give me, okay. Now let me go over presumptive. Now, you see that in the word presumptive, I put the U in capitalization and it's red, is because these are signs that are felt by the woman, you. Okay, there's a thing to my madness here, okay? You, the woman. All right, so I may have amenorrhea, which is what? Cessation of menses. Okay, you don't have your period anymore. Okay, but that's what the woman feels. Okay, but she might not be pregnant. Okay, these are what we call presumptive. Nausea and vomiting. Well, we know that it's caused by the increase of HCG, early pregnancy, hormonal changes. But is every time you're nausea and vomiting, does that mean you're pregnant? No, presumptive. Breast changes. Okay, may have some tenderness and tingling. Again, it's related from hormone changes. May have some even growth, but it's presumptive. Deepening pigmentation. You might have some what we call chloasma, or the mask of pregnancy, or the linea nigra, that line coming up. Okay, that's pretty good, but it's still presumptive. Is felt by the woman. Then you have urinary fatigue and quickening. Again, woman. Now, she might feel something move inside, but it could be gas. Okay, so these are things that are signs of pregnancy that are felt by who? You. Okay, so that's why I put the you in like that. Now, the next one is probable. You will see this one again, heads up. So these probable are evidenced by the examiner. Okay, the nurse midwife, the obstetrician, the nurse practitioner. These are things that what? They can see when they're looking. So like the Cordell sign, that's a softening of the cervix and vagina. You can't see it, the woman can't see it, but they can. Chadwick sign, heads up on this one, Chadwick. That's the bluish, purplish discoloration of the cervix and the vagina. What happens is a lot of congestion going on, the vascular congestion, and so it changes. And actually, you can see it very easily. The Chadwick. Hager sign, softening of the lower uterine segment. The woman can't see that or feel it, but the practitioner can, the examiner can. McDonald sign, that's kind of flexing the uterus against the uterus. So what happens is these are signs that are only by what? The doctor, the examiner, the nurse midwife. Okay, the woman, no, that's presumptive. Remember the you. Okay, these are probable. And the last one that I want to go over is called positive. And I put a little ultrasound picture in there because that's pretty positive when you're looking at an ultrasound picture. Yeah, you got a fetus. Yeah, you're pregnant. So you hear the heartbeat. The fetal movement is felt by the experienced examiner, and you have ultrasound visualization of the fetus. Okay, we'll break right here. Just take a fast, 10-minute break? Okay, 10 minutes. All right, all right. We gotta move forward.
Meeting is being recorded.
You're being recorded, so I'm gonna share your screen. Okay, so this slide just summarizes everything I just went over in detail with you. Okay. And so let me ask you the brain teaser. You ready?
Mhm.
Because let me tell you, you will see this again. All right. So an antenatal client is informing the nurse of her prenatal signs and symptoms. Which of the following finding would the nurse determine is a probable sign of pregnancy?
Chadwick.
Chadwick.
I love it. Yes, it is. Okay, good. All right. Very good. Now the next couple slides look pretty busy, but what they are is the normal physiological changes in pregnancy. And so I highlighted some of the stuff that I want you to remember, and I want you to just go over this. And you know that cartoon that I gave you? You can write some notes on that cartoon according to these slides. Isn't that nice? So this is how you would use it. So pregnancy in the endocrine system in the mom, the most significant change is the addition of the placenta as a temporary endocrine organ. Yes, the placenta becomes a temporary endocrine organ, and also the placenta is also a respiratory organ. Okay, it's temporary. It's going to go after she delivers. And it goes into like the amounts of estrogen and progesterone to maintain the pregnancy. Remember, what hormone maintains a pregnancy?
Progesterone.
Progesterone. Write that down and remember that. Okay, anybody guess that one wrong? I'm coming after you. All right, reproductive. Okay, so remember we talked about this last week. It's a pear-shaped organ. Again, the uterus, what? At term, it reaches up to the xiphoid process. And you know, in that uterus, you can have up to 5,000 mLs of fluid. That's between the fetus and the placenta and amniotic fluid. That's a lot of weight. Now, respiratory, moms, they breathe deeper and they take in what? More oxygen. They use up more oxygen. This is where what happens is that because the uterus pushes against the diaphragm up, pushes everything up, okay? All right. Now, the cardiovascular system changes. Now, what I want you to remember on this one is that volume increases. So volume increases, more blood being pumped from the heart, and the pulse rate increases. Just kind of write that down. Pulse rate increases by 10 to 15 beats per minute. It's on that little cartoon also. You'll see it when you later on, when you look at the cartoon. The GI, I told you how the uterus grows and is pushing against the stomach. Urinary, for little things, you got to go to the bathroom a lot. That's because the system excretes waste products for both mommy and fetus during pregnancy. All right, then here's your skin, integumentary and skeletal. So what happens is that you get these striae, which are called stretch marks. You know them as stretch marks, but it's called striae. And they do fade, after pregnancy. They don't go away, they kind of fade. But let me tell you, about when your child is about 50 years old, they become like silver. Give you just a little tip, trivia. All right. And then safety education is vital to pregnant. Why? Because her balance is different. Remember the waddling gait? That's because the pelvic bones, they're all kind of stretched out. They all have to be stretched out. Why? Because the uterus is growing. All right, makes sense. Okay. All right. So again, in these slides, we'll go over a little bit more about the endocrine, what's going on, progesterone needed to maintain your pregnancy. And again, the endocrine is responsible for producing hormones. And these are hormones that are produced. All right. Now, on the reproductive system, I added in here mucus plug. I kind of highlighted that. That's there to prevent any bacteria getting up inside the uterus. We already talked about cervix and how the changes in color and consistency, and the ovaries. And the ovaries themselves, they produce the hormone progesterone to maintain the decidua, which the decidua is your uterine lining. Remember I told about that hormone that maintains pregnancy? Progesterone, there it is again. All right, the effects of pregnancy. Well, you're in the vagina, you know, you have the different congestion going on. You have that bluish color, and you know what that is, but vaginal secretions. And then you have a higher glycogen level, which if you have a high sugar level, that's what that is. It promotes what we call yeast. And another term for yeast is Candida albicans. That's what, well, you know, a lot of ladies will complain of itching in the vagina during pregnancy, and that's because they have a little bit more yeast going on. And the breasts are there. You have the estrogen and the progesterone, which are getting the breast ready for what? Breastfeeding. And we went over this last week about the tubercles of Montgomery, and then your pre-milk. I'm kind of going fast over this because we go into more of this during the time we do newborn. So don't put these PowerPoints away, because sometimes you need to go back to them. Now there's a little drawing, comes right out of your book, and this is how we measure fundal height. Okay, we talked about fundal height. You can see my pointer, and so the practitioner has the bottom on the symphysis pubis. He comes right up the middle of the abdomen. And so right in the middle of the abdomen is called the linea nigra. And so all he has to do is follow that straight up. And he's putting the other part of that measuring tape on the fundus of the uterus. This is how you measure fundal height. And respiratory. Oh yeah, a lot of ladies will complain, oh, I just can't get my breath. That's because the diaphragm is raised up about 1.5 inches, guys. It causes the ribs to flare, and that's why she can have difficulty breathing until when? The fetus drops. Oh, that's a nice feeling. When that fetus drops, and she'll say, oh, I can breathe again. Oh, thank goodness. All right, because it's very uncomfortable. And because of increased estrogen, she can have edema, swelling of the mucous membranes, the nose, pharynx, mouth, and trachea. Now, I think there's an NCLEX question when you get there that will have about estrogen in relationship to like nosebleeds, the pharynx, the mouth, the trachea, like nasal stuffiness. Yeah, and a lot of ladies do have problems with nosebleeds during the pregnancy. Here you got on the cardiovascular system. If you got a blood volume increased by 45%, is that pretty significant? Yes, it is. So you need that though, because you're having exchange of nutrients, oxygen, and waste products within the placenta. Remember, the placenta is that very important endocrine organ, right? So the placenta needs a lot of nutrients and oxygen, and it's the lifeline for the baby, right? The placenta, and then you have the umbilical cord. Okay. And so by having an increase of 45% too, when she delivers, she can survive childbirth because she has such an increase in blood volume that if she does have quite a bit of blood loss at birth, she's able to be okay. All right. And again, we went over this already. The pulse rate does increase by 10 to 15 beats per minute.
That's right.
All right. Now, there is an increase in circulatory volume, which peaks between 32 and 34 weeks. So you have a pulse rate that increases during pregnancy. So like during early pregnancy, the woman could experience a reduction in blood pressure. And what factors can be contributed to this occurrence? And I put the answer right there, is reduced vascular resistance is responsible for the reduction in blood pressure. All right. So here, we have a syndrome called supine hypotension syndrome. That means what? The blood pressure goes down, right? So if a woman lays flat on her back, that's not good. She can get what? Supine hypotension syndrome. Because the uterus is heavy, right? We went over that. It could have about 5,000 mLs of fluid. So when your uterus is heavy, it compresses the inferior vena cava. So what happens is you have reduced blood return back to the heart. Now that she can feel fainty, lightheaded, dizziness, and agitation. Because she's like, I don't feel good. And when mom doesn't get enough, then that can lead to fetal hypoxia. The baby's going to get affected. So what are we going to do? We're going to turn mom to preferably the left side to relieve the pressure on the inferior vena cava. Now, you probably see this on exam number 1. So this is called supine hypotension syndrome. And you never, just remember something, guys. You don't lay a woman who's pregnant on her back. And thank goodness Mother Nature put that in there. So she doesn't feel comfortable enough for it, okay? So she wants to turn to her side. And I put this picture, and because this is like a pregnancy pillow, and she has, it's nice and soft, and she can, there's a pillow there to support the uterus. Can you see that? Remember, this is a pretty heavy uterus, and it throws her off balance, and it puts pressure on her inferior vena cava. It causes her to feel not so good, lightheaded, dizziness. And then you get baby that will respond by his fetal heart rate will go down. So here's a nice picture, it comes right out of your book. And you can see how by laying her on her back, the pressure of the baby in the uterus against her right here, her inferior vena cava, what it does, it compresses it. It makes sense. So what are you going to do? How are you going to take care of that, Mr. Nicholas? How are you going to take care of this lady? If you got her, if she's on her back and she says, nurse, I don't feel good. I feel lightheaded and I'm dizzy. What are you going to do?
Put it on supine hypotension
And
syndrome.
what are you going to do? What's your nursing intervention?
Yeah. Just put it on supine hypotension syndrome.
Right, and nursing intervention would be
Turn on her left side or put a wedge up under her hip.
put her on her side. Now the left side is preferable because you have better tissue perfusion, okay? But it could be right side or left side, but get her off her back. See the nice pillow that I just described to you? That nice and comfy, isn't it? Put her on her side, get her off. Okay. So these are different effects that can affect the cardiovascular system. And a lot of ladies can have palpitations. Now, you can have a condition, it's called pseudoanemia, and that just means that it's like something is pseudo, it's not really, it's called dilution. Is because there's so much blood volume that's going on. Red blood cells, there's actually too much fluid. And so what it is diluted. So it's not true anemia, but you want to be careful with it. And don't forget, increased clotting factors in the 2nd and 3rd trimesters. Okay, so let's do a brain teaser. So the nurse educating a pregnant woman in her last trimester will encourage her to sleep on her side because it will what?
Prevent
Prevent
hypertension.
hypertension.
That's right, prevent hypertension. You got it. Okay, let's move on. Okay, we got another brain teaser. No, we got here. Okay, let's go on. Okay, how about the GI system? Well, I tell you what, everything is kind of displaced, so she might not be able to eat like she normally could eat, right? Because she gets full. So you want maybe you want to make sure she gets her right nutrition. So you just tell her, you want to eat small meals. You want maybe more frequent small meals because she gets so full. Okay. Now, again, these hormones, progesterone and estrogen, if they relax the muscle
Tell somebody how much.
of the gallbladder. Okay, make sure you're on mute, please.
Is that where the heartburn comes in at? Or no?
Yes, exactly, exactly. You know, here you have your gastric acid secretions are decreased. And so that you have delayed gastric emptying and intestinal movement. Yeah. So, you know, I always say eat small, frequent meals, and especially as they get bigger. And so because you make sure that they get the nutrition they need without having that terrible, you know, esophageal reflux, because that can burn. And that's where that comes in.
I can't stand when like I have patients come in and say, oh, that means he just has very long hair. Just,
Yeah.
yes, long hair.
They say, oh, you must have had a lot of heartburn during your pregnancy. Okay. And here's just a picture. It comes right out of your textbook as to how the compression of abdominal contents as your uterus enlarges. Remember, the uterus, when it first started, it was down the pelvis. Then as the pregnancy, you know, develops and grows, right? It comes up out of the pelvis and into the abdominal area. So now it becomes an abdominal organ. And when you do that, there's only limited room in there. You know, you got your lungs, you got your diaphragm, you got your liver, so it's just limited. And so everything gets pushed up, and that what makes it so uncomfortable. All righty. And this is on the effects of pregnancy on the urinary system. And and what I want you to remember from this is that progesterone again causes renal, pelvic, and uterus to lose tone. So it leads to urinary stasis. This is not a good thing. Okay, because why? Because then she's more susceptible to a urinary tract infection. Okay, that's why we test it all the time, because we don't want UTIs, because UTIs equal preterm labor. Here's your skeleton and your integumentary, which is your skin. Striae, you got the spider veins, you got sweat and glands that become more active. Posture changes, low back pain. You have the relaxation of pelvic joints. That's where you get the waddling gait. And then for safety reasons, your balance. You know, you have a change in the center of gravity, and so the balance becomes an issue. Okay. That's why ladies that are getting their third trimester and you see them in high heels, I kind of cringe, because I say, oh no, do not take out the high heels, please. Because I don't want them to fall. Because when you fall, you can get placenta abruptio. You can have problems from a fall. Okay, this is just a safety alert that I put in here for you, so you can take a look at that later. All right, I want to get through because I want to make sure I give you all the brain teasers. And here's your nutrition for pregnancy and lactation. Remember to tell your patient what they're not eating for 2. Remember, how many calories extra do they get?
300.
300.
Right, 300. Good. So that's what you keep, and you make sure they're getting the right amount in their foods. And then here's some tips on your nutrition education. Read food labels. Make sure that they're getting what they need and not just empty calories. And these are about the RDA and the RDI. You can read about those. And here, this is an important slide. It's about weight gain. So I know on exam number 1, you have a question about weight gain. The normal weight gain is 25 to 35 pounds. Know that. Now, if she's overweight to begin with, then you have to tell her, you have to limit her to 11 to 25 pounds. That's pretty hard, okay? But they do it. Now, if you have ladies who are obese, again, you have to limit 11 to 15 pounds. Okay. So we went over this, increased calories by 300. A lot of times on exams, they love to put down protein, calcium, iron, and folic acid. So I made this slide for you just so that you can see that calories was 300, protein is 60 grams, calcium You need that. Remember I talked about the teeth and iron for anemia, 30 milligrams per day. I gave you on that other slide food that they should eat for the for this, and then their folic acid, at least 400 micrograms or 0.4 milligrams per day. And we talked about fluid, 8 to 10 glasses a day. So special nutrition considerations, you have your pregnant adolescent. And I think discussion question number 2 is about the adolescent. I'm really, really impressed by the submissions that I'm getting and reading. Okay, so doing a great job on that. Sodium intake, vegetarians. Yeah, got to go over and help them make sure what they're eating, they're getting enough. I talked about pike already. Lactose intolerant. What else can they take in? Cultural preferences. And then of course, gestational diabetes. And remember, I know you know about the pregnant adolescents often faced with concerns about body image. You have to watch them because they don't want to gain weight, because sometimes they're hiding the pregnancy for a while, and so they won't eat as much as they should. And therefore, if they don't eat, what happens to baby? Baby is small for gestational age. All right, then you have nutrition requirements for lactation. And we'll get more into this as we get into newborn, but just know that you need 500 calories more than the. So when I try to get somebody to breastfeed, I usually say, you know, you can eat more. You can eat more, you can have 500 more calories. And I usually get them to breastfeed. It's like, oh yeah, I can have that. Yes, yes, yes. Okay. And then protein, calcium, and iron, the same as during pregnancy. And vitamin supplements should be continued when they're lactating, and lactation is breastfeeding. And then drugs should only be taken on the advice of the healthcare provider, because drugs do go through the breasts. Okay, everything. All right. So you have to be very careful when you get there, when you do that. Exercise. Yes, they can exercise in pregnancy, and this is on your exam. But the rule of thumb is if they didn't do it before they got pregnant, they're not going to start during pregnancy. Okay. So the main thing is walking. Everybody can walk. And so they can do walking, and walking every day is good. And what we want to do, we just want to keep the maintenance of fitness. We're not looking for weight loss, and we're not looking for like muscle man, you know, or anything. No. Just to keep everything going. And it has been proven, my patients that were very active during labor, during the pregnancy, like walking and stuff, they did very good during labor. The peritoneal muscles are just like really, really and good and tight. All right. Now, because these are things that can happen to a woman who does too much exercise. Elevated temperature. An elevated temperature can impact fetal circulation and mom's cardiac function. Hypertension can reduce blood flow to the fetus. Fetus is going to take a hit. The cardiac output, too much peripheral pooling decreases cardiac reserves for exercise. So you got to be careful. And hormones, changes in oxygen consumption, like epinephrine, glucagon, cortisol, prolactin, and all that can have an impact on pregnancy. So what we want to do is, again, just maintain the fitness. And basically walking is really good. Okay. All right. And this just goes for some guidelines that you can read about nursing guidelines for exercise. Remember, we don't put a pregnant lady in a hot tub. No. It's you want to make sure she doesn't ever get overheated. And you know the old test, she's walking and you're walking with her and all of a sudden she can't talk, she's way over her limit. You need to sit her down and get her some fluids and relax for a little bit. And that's for anybody. If you're out there exercising, doing, but if all of a sudden you can't talk, you have to slow it down. Now, travel, there's always a question about travel on a exam. And so air travel is usually safe up to 36 weeks, folks, up to 36 weeks. But you have to tell them they avoid sitting for a long period of time. Avoid like locations that you would get exposed to like infections. You don't want to do that. Always bring a copy of the obstetrical record that you have, because if you go into preterm labor and you're in another city and you don't have any records, they're going to have to start all over again on all your blood work. So that's not a good thing. And then you want to know where you're going. If you're going from, say, Florida to New York, I want to know where I'm going in New York, that I have a facility that I can go to. And always, 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 we want them to hydrate before going on the what? On the plane. Okay. The question usually arises about how many weeks of station can they travel up to? All right. And then here's some common discomforts. And I already went over all these: fatigue, nasal stuffiness, nausea, heartburn, constipation. If you get constipated and you're not, drinking your water and having a high fiber diet, you can get hemorrhoids. Those are varicosities of the anus, vaginal discharge, backache, varicose veins, leg cramps, and edema. Okay, this is a lot, don't you think? Yeah, these are common discomforts in pregnancy. And I tell you, most ladies get this. All right. And this goes over the psychosocial changes. And we talked about that earlier today. All right. You have to make sure that you are aware of this, because pregnancy is a time of stress and changes for both the pregnant woman and her entire family. Okay. And the impact on mom, this is a lady that is very well known. Her name is Reva Rubin. And she identifies 4 maternal tasks the woman accomplishes during pregnancy. So what she's going to do, she's going to be concerned for herself and her fetus, right? Yeah. We want to make sure we have what? A safe passageway. Securing acceptance of herself as a mother and for her and her fetus. Yeah. Learning to give of herself and to receive the care and concern of others. That's a lot to learn, especially if you're a first-time mom. And then committing herself to the child as she progresses through the pregnancy. Okay, when she starts to feel the baby, that's a nice feeling, because then she says, a lot of ladies tell me, oh my, it's really real. Yes, it is real. Okay, because before that, you're pregnant, and you saw maybe a 10-week ultrasound picture, but you haven't seen another one for a while. And you may have your ultrasound at 20 weeks, and then they really get into it. And they go, really, I do have a baby inside. It's really phenomenal. It's beautiful. Now, fatherhood also has his own time. Fatherhood. How about when the pregnancy is confirmed, and you go and you tell the man, your partner, we're pregnant. Now, some are like, okay. Some go, oh, okay. And so we go through it from announcement to acceptance, and that results in strengthening of family. Okay, now he says, okay, I'm gonna be dad. Oh, okay. Then he goes through his own adjustment time, adjusting to now, okay, well, I have this really nice sports car. Okay, it's a red BMW. I really love it, but it's a 2-seater. So what do I got to do? I got to trade in my beautiful car, right? And what are we going to get? We're going to get a minivan. And so that's more for families, right? So that's what happens to dads. We have to go through this adjustment time, and then we focus. All right, now we're focusing. I'm going to participate in the labor and the birth process. I'm going to read that book, All You Want to Know About Pregnancy. And so he starts to now focus and help. That's nice. Really, hasn't the roles of fatherhood been changing over the years? Yeah, they're more active. And there's some cultural values that influence the role of fathers, because sometimes in some cultures, pregnancy and birth are viewed exclusively of what? Women's work. Okay. We don't get involved with that. But the nurse should never make assumption that a father is uninterested because he's not taking a role in the pregnancy. He might be, but in his way and according to his culture. And when they accept the pregnancy, this really results in strengthening of the family support system and, of course, the expansion of the social network. They go through a period, don't forget, they can't go out maybe with their friends like they used to. So they all have to come to grips. So things to think about. How and why has the role of the father changed over the past few decades? I think, what do you think? I think because women went back to work, and hey, here's a partnership here, right? It's more viewed as a partnership. And so I think that's one of the changes. What do you think? Real quick. Anybody have a story?
I think that they're involved a whole lot more. Back in the day, they weren't even allowed in the room while the woman was giving birth. Now they're expected to be there.
Yes, exactly. My career started in the labor room when daddies were not in the room. Yeah, I've been around for a while. So, yeah, I mean, I would have daddies crying, I want to go in with my wife. Oh, did you go through the childbirth classes? Did you get your little card? No, I didn't. Or yes, I have my card, but I left it at home. Oh, don't tell me that. So, those were back in the late 70s. I mean, they weren't even going in the room. No, not at all. How about your adolescent? Now, discussion question number 2 goes into an adolescent and to make guidelines and plan of care. So I've been reading those and pretty impressive, y'all. So I'm really proud of you. But just remember, adolescent is a time of change and adjustment. Yeah, big time. I mean, these young ladies, they're not in developed, and they may have just been their first period. Maybe just had their first period, and then they all of a sudden they're pregnant. And I've labored 13-year-olds, and and they just it's heartbreaking because their bones are not even well developed yet. So what you have to do is you always have to consider where she is in her developmental stage and how you take care of them. My little girl, she wanted her teddy bear in labor, and I made sure she got her teddy bear. Yeah. So think about it. Children having children, the impact of the adolescent. I think about nutrition. I always worry about what they're eating, making sure that they're taking their vitamins. I give them, when they came into the clinic, I give them a little more time because, I want to make sure that they were doing okay. They have to cope with life. It's a stressful time. And they have 2 stressors. They have adolescence and parenthood. And teenage pregnancy is a time that's so hard, and you have to really, really, really focus on their support system. Okay, because a lot of parents they go through a time period that they're not, they're not accepting it for a little bit. And what happened? What did you do? And it's hard for everybody. Now, here's a brain teaser. What would be the first priority in working with the pregnant adolescent?
Assess for sure.
Yes, to find out where she is, right? Assess her attitude. It's my first priority, right? It's what I want to see. I have to assess her attitude toward the pregnancy first.
Mhm.
If she accepted, what are we doing? Educating her. So that's the first one. Now we're gonna go real quick about the older couple. Okay, that's our AMAs, advanced maternal age, women who are over 35, and they're pretty much are set in their ways. Okay, and so they're most of the time are well educated. They have a good job. They make sure that everything is kind of lined up. And now they're ready to go into parenthood. What do you think? You think they have problems?
Oh, yeah.
Yeah, why? Because they have been successful and they have their way. They have their groups, okay? They like to go out to dinner a lot. Will all that change?
Yeah. My aunt and I were pregnant at the same time. I was 19 and she was 39.
Yeah.
So our babies are a month apart. And
Wow.
at that time, she was a lawyer. She had her whole life set out. So then she
Yeah.
said, I'm gonna come back and I'm gonna have a baby. And she
Yeah.
tells me to this day, both of our firstborn sons are both 21. And she's like, I would give anything to go back because I was tired and
Yeah.
couldn't keep up like you did. Like I was already in my 50s by the time he's graduating high school.
That's right. And that's the whole thing. So that's in a nutshell. That's very good. Thanks, Jessica, because that's true. They all have their, all these groups have their unique concerns. They have their unique adjustments. All right. So you just have to, when you have these type of patients, you have to see, and to the older couple, they have to come in for non-stress test more. We have to watch them a little closer. They because of the blood circulation, the edema, they're more prone. You have to be very careful that we watch them closer. And so now they may be lawyers and they have to come in and you're really what? You really are infringing on their freedoms. All right. Okay. And then some of them just decide not to get pregnant. They postpone it because why? Because they wanted to. All right. How about the single mother? That could be an adolescent or it could be a mature woman. They have their unique emotional needs too. Single women who plan pregnancies often are, often prepare for the financial lifestyle changes. A single woman, though, let me tell you, if you're a single woman, even if you have everything planned out, but if you have to go to work, because you're single, and your baby gets sick, what do you have to do? You're gonna have to
Stay
call
home or
in sick.
afford a nanny.
Yeah, you can't go to work.
Yeah, is that a problem? Yeah, it can be a problem. Sure, it can be. It's another stress factor. So, as you can see, pregnancy puts a lot of strain on the whole family. If you're single, you're an adolescent, if you're advanced maternal age, everything, right? It all has their own problems. So, and a single woman too, she might not have a support person. It's all according if the role of the father with this baby, is involved. Some are not. So again, she's on her own, and that's tough. That's really tough. The impact of the single father. He has to take an interest. Maybe he don't want it. Maybe he don't want to give up his BMW little car 2-seater. Okay. He's also going to be going through a stress. That's why it's always nice to have all this planned out. Wouldn't it be nice? Now, impact on the grandparents. Again, this is all family dynamics. Usually the family, the grandparents, they usually like to take an active role. Oh yeah, grandparent is nice. And just to go over prenatal education, I put in here is according to the nursing process. And so we'll be looking at this as we study too, about using the nursing process, one, to assess the history and cultural needs, diagnose the knowledge deficit in your patient. Always. That's always, let me give you a hint. That's always a good diagnosis, is knowledge deficit related to. And then plan your goals and priorities, your outcome. We want a good outcome. And we're going to teach facts and evaluate our knowledge gain or goals achieved. Does that sound like the nursing process? Yeah. All right. And this goes over lactation, and we will get into more of this during the breastfeeding time. But just know that pregnancy affects the metabolism of medications. And so these medications may not have the therapeutic level that they should. They may have what we call a therapeutic level. And then sometimes medications can be absorbed more rapidly due to increased cardiac output. Because remember, increased cardiac output is increased by 45%. And remember, drugs do cross the placenta. What mom takes in crosses over the placenta right to baby. So if mom taking cocaine or any of those illegal drugs, they go right through the placenta, cross over the placenta, right to the baby. And then we'll get into that when we get into newborn. These are category of drugs you may have seen already. Category A, there's no risk, and category X absolutely does call fetal abnormalities, and you probably see that in your drug book, but I just kind of put that in there for you because we do want to make sure that whatever we give our patients, that the risk, right? We want to diminish the risk and the benefits are there. All right. And this is pretty good because I talked about this before, but we do not give live viruses vaccines. Do not. They are contraindicated during pregnancy. So that's why we avoid, the measles, mumps, and rubella, and we don't give rubella. Now, when we give rubella, she has to, if she's not pregnant and we give rubella, she has to wait a full 1 month before she gets pregnant. So there's a waiting period for that. Okay. All right. And so if you gave her to her after she delivered, okay, postpartum, she cannot get pregnant for a whole month. Hopefully she doesn't, but sometimes they go home and they get pregnant again. Okay. But they can have like influenza vaccine, and they can have what we call the Tdap vaccine. All righty. And like Looney Tunes used to say, that's all, folks. All right. So congratulations. We made it through. All right. Okay, take a deep breath. Let me stop sharing my screen. Wasn't that great though, right? Wonderful. Okay. So what I'm going to do now is it's just barely 4:59. We're right on target. All right.
Somebody left a message for you in the chat.
Oh, thank you. But you got to take, okay. Oh, okay. That's okay. They had to switch classrooms. As long as they come back. Okay. Because I'm going to give you a 10-minute break and come back and we're going to do the quiz. I want you to relax for a few minutes, go to the bathroom, get something to drink, come back 10 minutes. So it's 5 o'clock. Be
The
back
quiz
at what
gonna be
time?
on Canvas.
I can't, huh?
The quiz gonna be on Canvas where?
Yes, it's on campus.
Mhm.
All right. So that means you have to have your Canvas so you can get on Canvas, and I have to be able to see you. Okay. Just like we do for exams. All right. Go take a break, get something to drink. Be back at 5:10.
I had a question, Ms. Dunham. As far as because we have an exam next week, right?
Have a quiz.
We don't have an exam next week?
Nope, your exam, let me tell you. I'm looking at my trusty old syllabus. And your first exam is on January 31st.
So what is that, week 4?
That's week 4.
Okay,
All right.
okay.
So next week is quiz 2. And I'll do the same thing. I'll give you a study guide. Well, I'll try to name it something different because I don't want me to give you study guides. I'll do the same thing I did this week. Fill in the blank. Okay, take a few minutes, relax your brain now. Thank you for your attention during the lecture. Hope you had fun.
Yeah.
Quick question. Did she leave? She left.
Here, yeah.
Hi, sorry about that. So are we doing the whole log into Zoom on our phones and prop that up so you can see everything?
Yeah.
Yes.
Just like you do for exam. Yes, ma'am.
Okay.
Wait, how are we doing this? I've never did one online.
Oh, no? Okay,
I've never done this.
I tell you what, you got 15 minutes to do the quiz. At 5:10, come in and let me just stay on Zoom, because I don't want you to come off this Zoom, because then your times will be skewed. So stay on this Zoom, just come back into the classroom, okay?
So we just keep the Zoom up on our computer and we just have Canvas open on
Yeah.
another. So
Yes.
we're
so-
okay with this, just move everything off the desk or something?
Yeah, yeah, don't worry about it. Keep on this Zoom so we don't lose our time, okay?
Okay,
And then you just do your Canvas, okay? You go
Okay.
do your quiz at 5:10, come back and I'll go on from there, okay?
okay, do we do scrap paper for that
Yeah,
math?
sure, yeah, for your math. Here's one math question. Okay? All right, I'll see you back in a few minutes, okay, sweetheart? Okay. I don't think we have to do that.
Ô, garçom! Abre lá tudo só igual o Portugal. Bota ali gengol. Bota ali gengol. Olha essa sabe lá no Brasil. Oi. Ele é muito na village lá. Vai lá fazer. Mana mau di mana
Yes. Mais moi, le soir, est-ce que je vais voir quoi? Il dit que c'est ça de courir. Emmanuel, kalau kita semalam wendik sih, memang kalau mana kita tuh memang kalau kita sekali wendik sih kita nonton live ya. Uma applicação. Mas ele ela caía lá meteu email na minha. Eu se contato ele que account manager, você quando ele tá na escola, eu vou entrar no account.
Okay, everybody. It's 5:09. Go ahead and go into Canvas. Go to quiz 1 and do your quizzes.
I'm sorry, are we doing this on our phone? I'm a little confused. Or are we minimizing this or what?
Yeah, you can minimize it. You can do it around your computer. I'm not going to watch you. Just do the quiz. You have 15 minutes to do the quiz.
Just minimize it.
We don't have to switch over to our phones now. We can just leave it on the computer and take our quiz that way.
Yes, ma'am.
When we're done, do we hang up?
Well, it's 15 minutes. So that would get us to 5:25.
5:25.
And I can go over with you.
We can do it over the phone though.
Okay, so all you have to do is still stay on Zoom so you have your attendance recorded. Okay? All right, everybody?
That everybody's is muted, like people are not muted.
You can minimize it. I'm not going to watch you. You're on, you're set on your own. Take the quiz. You got 15 minutes. Good luck. Read each question. And make sure that you mute yourself, okay?
Yeah.
Okay, everybody, so welcome back. So I'm gonna go over the quiz real quick with you. All right, so everybody's finished? Have your grades in here? Yep, okay. Just making sure everybody's finished. Okay, so the first one, the nurse caring for the pregnant client must understand that the hormone essential for maintaining pregnancy is what?
HCG. Progesterone. I'm sorry. Progesterone.
Right, progesterone. Okay, good. The number two, the nurse knows that teaching is successful when the student nurse states the following are all characteristics of amniotic fluid, except
Providing nutrients.
Nutrients.
The waste. It's the waste.
right, you're correct. So the correct answers is allows for fetal movement, maintains body temperature of the fetus, and surrounds and protects and acts as a cushion for the fetus. Okay, good. The next one, this is your Nagel's rule. So a woman's last menstrual period began on May 4th, 2022. Using Nagel's rule, which date would be correct to estimate her delivery date?
February
February
11th.
11th, 2023.
Correct. Did you see that before? Okay. The next one. An antenatal client, is informing the nurse of her prenatal signs and symptoms. Which of the following finding would the nurse determine is a probable sign of pregnancy?
Chadwick
Chadwick.
signs.
Yes. Chadwick. Okay. All right. A client enters the prenatal clinic and she states that she believes she's pregnant. Which of the following hormone elevations will indicate a high probability that the client is pregnant?
That one's HCG.
HCG.
Human
Yeah.
gonadotropin.
Human chorionic gonadotropin, HCG. You are correct. Okay. The next one, which term is used to describe the process of a fertilized egg attaching to the wall of uterus during early pregnancy?
Implantation.
Yes, that's right. Ta-da! Okay, the next one. A client is coming in for her first prenatal visit, and it is determined that she's 8 weeks pregnant. So which tests are typically performed at the first prenatal visit in a low-risk pregnancy? Select all that apply.
HIV.
Except for
All
the
of the glucose.
BC, rubella.
All but the glucose.
Yeah.
Right. All but the glucose. Now, if you got that one wrong, okay, then you need to go back onto that PowerPoint. All right, or into your book. Okay. The next one. This is your GTPAL. A pregnant woman presents at 8 weeks for her first prenatal visit, and she gives the following obstetrical history. She had a vaginal birth after cesarean at 40 weeks.
1.
She had a spontaneous abortion 3 years ago.
1.
She had an emergency cesarean at 32 weeks 4 years ago. And she has 2 living children. So how would you rate her GTPAL?
41112.
Exactly.
Can we, because we're just going over, is it okay? It's 5:30. If we're done, we're done. We can go
Yeah.
ahead and log out. I'm sorry,
Yeah.
ma'am.
Yeah, just
Thank
make
you.
sure. That's fine. I'm going over this for those that need it, but go ahead if you need to.
Thank you very much. Bye.
You're welcome. Have a good evening.
confused with that question.
We got one more. We're doing good. So the nurse is teaching health class about the 4 types of female pelvises. Which pelvis is optimal for passage of the fetal head?
Gynecoid.
Okay, correct. And the last question. So the order is orodasterone sulfran 6 milligrams PO liquid solution. Okay. On hand, you have orodasterone sulfran 10 milligrams per 2 ml. How many mLs will the nurse administer? Round to the nearest 10th.
1.2.
1.2.
Exactly. All right. There you go. It's 5:30, 5:31. We did good. Y'all keep reading. Y'all did
Miss
good.
Dunham,
Okay, thank you.
Okay. You're
have
welcome. My
a
pleasure.
Bye, everybody. Have a great evening.
Bye. Have a good night.
Have a good night, everybody.
Miss Dunham,
I am here.
for that math question, do you have to manually go in and put in the correct answer for us to receive credit for it?
Oh, yeah. Yeah,
Okay,
you have to put in 1.2.
okay.
Now you have
Because-
Zoom user on your, so put your name in the chat, okay?
I did.
You did? Okay, all right. Try not to have Zoom user. Okay, everybody good?
Yeah, so I do have a question because I had all my answers correct, but on the math, I did put 1.2 ml. So I don't know if that knocked it off and, didn't give
Probably
credit
did.
for it.
What I'll do for you is I'll go back in myself and correct it. But don't
Okay.
put mLs on the math on these Canvas, nor
Okay.
on ExamSoft.
Well, I know you're on exam soft, but okay.
Stay on Canvas.
Okay. Well, okay. Thank
I'll look
you.
at that on everybody, make sure. Okay,
Okay.
you're welcome. Everybody good?
Nick, you're on mute. So if you got to ask her a question, take advantage because I have my own for her. Okay, we have to share. So take your phone off mute or your computer and ask her your questions.
I was trying to read his lips. Yeah. You're on mute. Here, let me help. Let me see if I can help him. Here.
Nick on the bottom.
We got it.
Yeah.
Okay. Okay.
You asked me to put my name on chat. Where?
Oh, go on chat. You see it on the bottom screen. It has a cross, or it could be on the top screen, and it has the word chat. Click on that.
Look under her screen. Look under the professor's picture.
Okay.
And you see chat.
Chat. Okay.
Just put your full name in.
I click on it. Okay. Okay.
Yeah.
Correct. Last time I didn't do it.
Ooh.
Oh, so you were absent. Okay. Your phone user.
I'm not, you can correct that for me. Well, I get confused between progesterone and estrogen. I put progesterone for that question. Although I have the hormone essential for maintaining.
No, it's progesterone. It's progesterone. Progesterone.
I put progesterone. Hmm?
Oh, so you're right.
Yeah, I put progesterone.
Okay.
Oh, I get it over 8.25. I think I should have more than that.
On
Well,
what?
let's look at your.
I get 8.25 out of 10.
Well, you got some on all that apply. Did you miss an all that apply?
It might be the GT. It might be the GT power. I call it that. I think it
I
might
put
be
GT,
that.
but I take HIV. I just take 3 on all that apply. I got 3.
Yeah, that's where you lost it.
Yeah, you missed it on that because the glucose is the only one that you test at like around 26, 27 weeks. So that's the only one.
Yeah.
Only one. Oh, I put glucose. I put 3. That's
yeah.
That dropped my grade.
Yeah.
Anyway.
Okay.
It was
Bye,
good.
baby.
Thank you for everything. Thank you for
You're
everything.
welcome. You're
Nick,
welcome.
I'll see you in the morning.
See you in the morning.
You'll keep reading.
Yeah. All right. Thank you.
You're welcome. Bye-bye.
Bye-bye. Have a good one.
You have a good night.
Alrighty.
Likewise.